person in gym dies is a headline, but person sitting at home watching TV is never a headline. I think it's important for listeners to understand what is a heart attack and what causes it. Of the young person, 40, 45, taking care of everything and it happens out of the blue. If we want to prevent anything from happening, we need to understand why it takes place. There are risk factors. There are two which you cannot change.
We hear about heart attacks in young people. So there's also a fear in some people's mind that there was somebody in my family who had a heart attack.
Unfortunately, where the heart is concerned, there is nothing like one test gives you everything. We have people coming in every day, Doc, what's the one test to do?
So I have a new guest here today, and I'm so excited for him to talk to you all. He's actually a good friend, but you might know him as one of Mumbai's most famous cardiologists. He's the director of the Rehabilitation and Sports Medicine Department at Sir H.N. Reliance Foundation Hospital. And he's also the certification director of the American College of Sports Medicine for India. That's how I first got to know him. And for 11 years now, he's been the director of the Mumbai Marathon from the medical side. So Ashish, thanks for being here. You walk the talk, and you're a doctor who knows fitness, who applies it in your own life, and you bring it to your patients. So I'm so glad to have you.
Thanks, Roshani. It's a great pleasure. Always chatting with you and looking forward to a really exciting talk today.
So Ashish, I've known you for so long, and I've never actually sat down and asked you that. I know you're a cardiologist, but I don't know how you got into exercise and preventive cardiology, rehab cardiology. How was that? How did that all happen?
So, Roshni, that's an interesting journey. I've always been very interested in sport all my life as a spectator and as a sort of semi-athlete myself. So after I finished my MBBS, I explored what are the, if I may say so, offbeat, something different that one can do. And sports medicine seemed very attractive. So I did my research and found out that I would need to go to the US because there wasn't really a focus on sports medicine in the mid 90s in our country back then. So I went to the US and started studying sports medicine. And there my eyes opened up even further, where I realized that sports medicine isn't just treating injuries of an athlete. It includes many sub branches. So, for example, sports psychology, sports nutrition, all of that's part of it. And I found a lot of interest in the whole sports physiology, exercise physiology, sports cardiology. So basically using exercise as a means and as a tool, almost using exercise as medicine to kind of take care of the human body. So that's how the road sort of meandered to sports medicine, preventive cardiology, sports cardiology.
Wow. I wish every doctor was introduced to exercise that way, right? I had to actually become a personal trainer to understand about exercise. And that's how I found out who you are, in fact, is that you're the one who brought American College of Sports
Yes,
Medicine.
I've been associated with the American College of Sports Medicine now. Gosh, it makes me feel old, but 1996, so that's like 28 years. And we started the certification programs in India in 2003 to kind of get the whole scientific aspect of exercise into the field.
So more than 20 years now you've been teaching exercise. And who are your best students? Like, do you see doctors or who comes to learn about this?
So, people like you who have an interest in healthcare, medicine. We have a lot of people like physiotherapists who are interested. We have personal trainers who then want to go on and do more stuff related to the scientific aspects of it. And we also have a lot of people, if I may use the word lay people, bankers, lawyers, who have developed a deep interest in sport, in exercise, and want to kind of take it to its logical conclusion and be completely educated around it just for themselves, not wanting to use it in any sort of commercial manner.
But that's so good, right? It can empower anybody to actually, and you've named it also, right? Exercise Science Academy. Because there is a science to exercise. I mean, sure, you can go and move your body and play and not be so rigid about it. But knowing the science actually helped me. For example, I thought I knew about the human body, but as a doctor, I knew about it once it's broken down, injured, like you said. And learning the personal trainer course helped me prevent my own injuries, where I suddenly knew, oh, when I'm doing a squat, how should I make sure I'm taking care of my spine? So I feel like, yes, it can empower anybody from any walk of life who wants to know what exercise is all about. And typically, we think of a cardiologist as someone who treats you when you have a heart attack. And now I'm realizing that you always wanted to be on the side of maybe preventing those heart attacks.
Absolutely. Yes. Yes.
Amazing.
Yes.
So, most people don't have a scientific background. And the awareness in India, thankfully, is going up that we should exercise, we want to exercise. Fitness is becoming a culture. Also, we have this epidemic in India of metabolic health, cardiac disease. We hear about heart attacks in young people. So, there's also a fear in some people's mind that there was somebody in my family who had a heart attack. And the thoughtful person might say, should I get tested? Who should get tested? And can you help us understand how you would think through someone who just walks in and says, I want to start exercising? What tests should I do?
Okay, so there's a bunch of different aspects, to your question, and maybe let's start at the beginning. Since you spoke about the heart and a heart attack, I think it's important for listeners to understand what is a heart attack and what causes it, right? So your heart is a muscle about the size of your fist, and its job is to supply blood to your entire body. So it acts as a muscular pump. Blood comes in and blood is pumped out. Now, to do that activity throughout life, it's pumping, it's beating right from the time you're born till the time you die, which is roughly, if a person lives to be about 75 years old, I did the math, it's roughly 3 billion, that's 3,000 million heartbeats, in a lifetime. So the heart is constantly working. And to do its work, it requires blood supply, it requires energy. And that energy comes from blood vessels called coronary arteries. Now, when there's a blockage in the coronary arteries, it prevents blood supply from reaching the heart muscle. And if that blockage at some point breaks, ruptures, becomes too big, it completely cuts off blood supply, and a portion of the heart muscle actually dies. So the technical word, as you know, is myocardial infarction. Myocardial is your heart, and infarction is death of the heart muscle. Now, getting to the point of why does it happen? If we want to prevent anything from happening, we need to understand why it takes place in the first place, right?
Sure.
So there are risk factors. There are two which you cannot change, right? One is your age. As you go up, your risk for heart disease, cancer, stroke, it all goes up. Second is family history. If your immediate family, mother, father, brother, sister, especially if they've had heart disease, your risk goes up. Doesn't mean you have to have the problem, it just means your risk goes up, right? So we can't change those two. So what can we change? The first and most important is cigarette smoking, tobacco consumption. Second, which you're the expert as, is diabetes. In fact, today diabetes is such a serious condition that cardiac societies call it like a heart disease equivalent. So if you've got diabetes, we take care of you as if you have heart disease, right? So smoking, diabetes, high blood pressure, high cholesterol, physical inactivity, non exercising regularly, excess body weight. And the last factor is something which we cannot measure, which is sort of stress and mental health. We put the whole stress, anxiety, depression into sort of one cubicle. Now, those are things you can't measure. So all of these risk factors contribute towards you having heart disease. Sometimes somebody has one or two of them and has a problem, and there are some people who have many and don't have a problem. It's kind of like a car. When you're driving a car, you need to take care of several different risk factors not to have an accident. You shouldn't be speaking on the phone, your brakes should be fine, you shouldn't be speeding. Sometimes, however, you find people doing all things wrong and they don't have an accident. It's the same thing with the heart. Sometimes people have all things going wrong, but they don't suffer. And on the other side, sometimes you're very careful, you just stop quietly at a signal and someone comes and rams you from behind. So that's the case of the young person, 40, 45, taking care of everything, and it happens out of the blue. But let's say that those are 5% on each side. 90% of the times, if you take care of these risk factors, you reduce your risk. Now, to address your question directly, what test should you do, right? That's the $1,000,000 question. We have people coming in every day, doc, what's the one test to do? Or give me, I want a complete checkup. Now, unfortunately, where the heart is concerned, there is nothing like one test gives you everything. Let's just walk through some of the very common tests. So, even before you do any test, one must know the risk profile. So, to know your risk profile, all you need to do is, of course, take your body weight and height, which will give you your body mass index, measure your blood sugar, measure your cholesterol, measure your blood pressure. It's extremely easy and inexpensive to just get this done. So this gives you your basic risk profile. Now, in addition, Let's say you do an ECG. An ECG is an electrocardiogram. That's the electrical recording of the heart. ECG is great at telling you what's going on now, at this moment, if you're having a heart problem, a heart attack, or if at this moment your heart is missing a beat.
So if I was to walk in for a health check and say, do the ECG now,
Yeah.
that doesn't tell me I'm not going to have a heart attack.
Absolutely. It's going to tell you here and now. It's a great test to say, I'm getting chest pain right now. Let's get it checked out. And an ECG can reasonably accurately tell you whether you're having a heart attack now.
On the spot.
On the spot. It cannot tell you whether you will have an attack 2 hours from now or 2 days from now, right? So that's a basic ECG. Then people talk about a 2D echo or an echocardiogram. An echocardiogram is like a sonography of your heart.
An ultrasound.
Exactly, the ultrasound. So what it tells you, what is excellent at telling you at, is how the valves are functioning in your heart. So the valves allow one-way flow of blood, and sometimes for various reasons they get tight or they get extra loose. So the echo can tell you that. The echo can also give you an idea about your pumping capacity of the heart. The technical word is ejection fraction.
So you're seeing the muscle, you're looking
Yeah,
at the muscle.
absolutely. The doctor is actually seeing it beat, and a regular ejection fraction or a normal ejection fraction should be somewhere in the 50 to 60, 65% zone.
What is an ejection fraction?
Okay, so let's get into that. I told you your heart is a muscular pump. Blood comes in, blood pumps out. But all the blood that comes in, let's assume that say 100 ml of blood comes in, and when you pump out, all 100 doesn't go out in each beat. Roughly 50 to 60 goes out. So about 50 to 60% of the blood that gets filled in goes out in each beat. That's your ejection fraction.
So many people get this misunderstanding that I had a heart attack and now my heart is pumping 30%. And they think that my heart, it's like I got 30% marks on my mark sheet where I'm supposed to get 100 on 100 and I'm getting 30. But what you're saying is we should be a topper in the heart is pumping how much? 65.
60.
60 is a high score.
So it's a range. It's roughly 50 upwards, but say 55 to 65. And that's an excellent point to bring up because people tend to think that 100 is normal.
Right.
And when you're told it's 45, for example, it's very disappointing because in your head you're thinking 45 out of 100. But it's 45 out of, so to speak, 55.
So the high you're looking for is 45, 55, 65.
Yeah. So if your heart muscle has been damaged for some reason, which could happen post heart attack, echo could tell you that. That's why you have sometimes people do a test and the doctor says, hey, you might have had a problem in the past.
Like a silent heart attack.
Yes, because they see the heart muscle compromise. So that's the ECG, echo. Then a common test is a stress test. So what does a stress test do? So stress test is not like you're sitting in a room and they're just sort of mentally stressing you out, okay?
Yeah, that happens every day.
Yes. So they put on an ECG and they get you on a treadmill and the treadmill goes quicker and quicker every few minutes. So it's a protocol which is designed to essentially tire you out somewhere between 6 to 12 minutes. It's pushing you to your max. So it's so-called stressing your heart. And then at the same time, we're looking at the ECG. That's why we call it a functional test. When you're asked to perform, how does your ECG work? Does it change? And if there are certain changes on the ECG, then we call it positive. Unfortunately, medicine somewhat convoluted, right? When something is bad, we call it positive. So a positive stress test is a bad thing.
So you never want a positive stress test.
Don't want a positive stress test. So we look at how the ECG works. You also look at symptoms. If a person's having chest discomfort, if they're having unusual shortness of breath in proportion to what they're doing, then those are signs and symptoms. So we look at your basic profile. You can do an ECG, 2D echo, stress test. This is a great sort of starting block of testing.
So it's like 3 viewpoints of the heart.
Exactly.
One question about the stress test
Yes.
is if someone comes in to see me or they're thinking about getting tested
Right.
and they've never run on a treadmill in their life,
Yeah.
how will they perform and you push them?
Good question. So, which is why we sometimes allow them a minute or two just to get used to it, and it starts really, really slow. The first stage of a stress test is a very slow walking speed. It's roughly 2.5 kilometers per hour. So, like a very slow walk. The only difference is it's up a slope. The most standard protocol used worldwide is called a Bruce protocol, which goes up every 3 minutes. So, it starts with a fairly steep incline, but it's slow. So most people get used to it and most people hold on. I mean, in an ideal world, it would be nice to do a stress test without them holding on, but they're too nervous about their balance, so they hold on. So that's not really hard.
Okay, so you can use that. And so these
Yeah.
three would be a good place to start. And
Yes.
if all three look okay, then can somebody start exercising?
They certainly can. And one second, let's take a step back. You don't have to do all of this just to start exercising, okay? So the general guideline is that if you're completely asymptomatic and your risk profile is low and you want to do what we'll call just moderate exercise, so let's call it as a brisk walk, a fast brisk walk. Let's use that as a cutoff for moderate exercise. So if you want to do moderate exercise or something less, you don't have to get all these tests done,
Okay.
the stress test, etc. Okay, it's good to know your risk profile. Every adult should know their risk profile. And if their risk profile is a low risk profile, you don't have to do a stress test before you get started on a regular low intensity exercise program. However, you want to do some high intensity stuff, you want to go run long distances, you want to lift heavy weight, you're over 35, then it's a good idea to do this. And again, the truth of the matter is in our country, luckily, these are very accessible and relatively inexpensive. Most of these tests by themselves cost less than a reasonable meal at a restaurant today.
Got it. And this low risk, medium risk, it's not me just imagining my risk. There are standardized sets
Absolutely.
of
There are
questions.
algorithms, there are risk questionnaires which one can do online. The ideal thing is talk to a
A
doctor
doctor.
who knows you, knows your body, understands you, who takes a nice history and then decides which is the best test to do.
Right. And I remember that from your course is that
Yeah.
there are ways to park people in low risk,
Yes.
medium risk, high risk,
Right.
who should get tested.
Correct.
So again, it makes sense to talk to someone who knows
Understand. Yes.
about the exercise prescription,
Absolutely
right?
right.
Whether to self-prescribe and get started
Right.
there. So Ashish, you've written a book. I've written a book. We're all into this preventive health space. And there's another doctor who's written a book. It's called Outlive.
Correct.
And I think in the spirit of the book, it's similar to what you and I believe in is let's teach people what they can do to stay healthy and extend their lifespan. He's using the word longevity. And of course, the heart plays a big role in longevity. So when someone wants to start exercising to build up that long lifespan, there's something that he talks about, and it's not his new idea, it's been there in the world. And maybe Phil Maffetone was the first guy to talk about zone 2 training. So people, my husband's a cyclist and you're a runner and you're attached to the Mumbai Marathon. And I think people want to know what is zone 2 training. They don't understand. How do you monitor heart rate?
Okay. So, just as an aside, I met Brian Johnson when he was in Mumbai last week. Since you spoke about longevity, he's all over the news
Yes.
for wanting to live forever, right?
Yes.
And I've read Peter Attia's book, and I think it's a very good book. So that's great as well. What Zone Two is saying is that when you're exercising, it's normal for your heart rate to go up. So when you exercise, your heart rate should go up. An average resting heart rate is, say, somewhere between 60 to 80 beats per minute. And when you start exercising, it goes up in a logical, sequential manner. Okay, it goes up in, technically speaking, a linear fashion. As your exercise effort increases, your heart rate goes up. Now, there's a lovely formula, which is 220 minus your age for an adult, which is what's called your age predicted maximum heart rate.
Maximum heart rate.
Yes, age predicted maximum. So if you're 40 years old, for example, it's 220 minus 40 is equal to 180. Now, the actual way to check if that's true or if that's accurate for each individual is to do a stress test. And you push them to maximum. That's each person. But if you don't have the luxury of having a stress test in front of you, you take 220 minus your age. And then what zones are is they are a percentage of your maximum. So they're a percentage of the 180 in this example, right? So different people define zones slightly differently, but a very simple one is if you're going, say, zone 1, 2, 3, 4, 5. So 1 will be roughly 50 to 60-ish percent. 2 will be about 60 to 70, 75%. 3 would be in that sort of 70 to 80%. 4 would be 80 to 90, and sort of 5 would be
All the way.
all the way up.
So if a 40-year-old
Yeah.
their maximum would be 180.
Predicted maximum.
Predicted
Yes.
maximum on
Yeah.
paper before we
Yes.
test them.
Yes.
And so their zone 1 would be they're sitting in a chair and it's whatever at rest.
It's possible, yeah. If you do the math, and depending on what that person's resting heart rate is, but it'll be typically higher than resting heart rate. Because if resting heart rate 70, if the person's 18 years, if 180 is the maximum, then you do 180 into 50%, that's still 90. So zone 1 will be more than resting.
More
It's
than
not- yeah,
resting.
it's not
Okay, so
resting.
it's already more than resting.
Yeah.
And then I'm just trying to think of what are the numbers people are thinking about.
Yeah.
So because they may not think in percent.
Yes.
So a zone 2 for a 40-year-old would be, if 180 is their max, we're looking at it being about,
Let's say 70% of 180, right?
Okay.
So that would be
so whatever
what's-
the math is for that.
Yeah, about 125 on
Okay,
something like that.
fine. And so then it just keeps going up from there.
Yeah.
Okay, so then why do we care about zone 2?
So I'll tell you a simpler way to figure out
Yes.
zone 2, right? We also call it a talk test.
Yes.
If you're exercising and if you're able to carry on a conversation with someone next to you reasonably comfortably, they say if you can talk but not sing, that's a good sort of zone to be in. Earlier, we used to use, or we still do, what's called the BOG rating of perceived exertion. Perceived exertion means how hard you feel you're exercising. And we tell people to be in that fairly light to somewhat hard zone. So I tell them, like, it's not like you're strolling in a park and picking up the roses and smelling them. It's not that, easy, but it's not that hard that you're sort of panting and you're out of breath and, you can't even have a conversation.
So you're not finishing, you are able to finish sentences.
You are able to finish a sentence. The idea why zone 2 has become popular is that you can stay in it for a reasonable length of time and you get a nice long endurance bout in it. Now, the irony is that few years back, HIIT, high intensity interval training, was the in thing. So we keep yo-yoing. Like at one time, running barefoot was the in thing. Today, not only are shoes cushioned, but they're this fat, some of them, if you see them, right? So we keep going back and forth in these trends. So today's zone 2 is a trend. And what they say is, even if you're doing long distance training, people call it sometimes the 80-20 rule. 80% of your training, your base, should be at a comfortable zone. Whether we call it 2, 3, it should be at a comfortable pace. And 20% should be at a slightly higher pace. One more advantage of that for people who like things like fat burning, etc., and this is a bit of a nuanced topic, so let's spend time on it. Fat burning. People love to burn fat.
Everybody wants to burn fat.
Right? Fat burning is more when you're, as a percentage of your total caloric burn, when you're at a lower zone, like say in zone 2.
So if you have a 1-hour workout, if you spend most of it in zone 2,
Correct.
you're going to be burning fat.
You're going to be burning, let's rephrase it, you'll be burning a higher percentage of your calories as fat. So let's say if it's very relaxed and you're burning 6 calories per minute and you're doing 60% fat, then you're doing 3.6 calories per minute of fat, absolute calories.
So fat
right?
is
as a
contributing.
percentage. But as your intensity gets higher, your percentage from fat comes down and percentage from carbohydrate goes up.
Okay.
But here's the kicker.
Yeah.
Your absolute calories start increasing. So let's say at a low intensity, you're burning 6 calories per minute and you're doing 60% fat. That's 3.6 calories, right?
Yeah.
But now let's say you're at a high intensity and you're burning 10 calories per minute, and instead of 60% fat, you're doing 40% fat. So how many is that? 4 calories. But now you're burning 4 calories of fat versus 3.6.
Oh, it's of a bigger number. A smaller
Correct.
percentage of
So,
a bigger number.
so basically, when you and I are resting, so first rule is the body almost at all times is burning a combination of fuels. It's rarely pure fat, pure carbohydrate. The only time it's almost close to pure carbohydrate when you're maxing out at your 100%. Okay? So when you're at rest, more fat, less carbs. I'm just using more and less as terms.
Yeah.
As you start exercising and your intensity starts increasing, it starts crossing over to less fat, more carbs as a percentage. There's something called a crossover point as well. Okay. So therefore, a lot of people will tell you exercise at a low intensity if you want to burn more fat, which is true, but it's partly true. Because if you're burning at a higher, exercising at a higher intensity, you're actually burning more calories overall.
Okay.
And depending on the number, you may be also be burning more absolute fat calories. So let's just distill it and make life simple.
Yeah.
I tell people that select a time which is comfortable for you. Let's say it's 40 minutes of exercise. So in those 45 minutes, start at a gradual pace. And as you get fitter and fitter, you will start increasing your intensity. So the goal is to try and do a reasonable amount you can in the time you have, because there's always an inverse proportion between intensity and time. The harder you go, the less
Sure.
time you'll go for.
Yes.
So select a time. Typically 30 to 60 minutes for endurance work is a sweet spot. Also, in terms of time availability, it's a nice sort of sweet spot. Select that time and slowly keep increasing your intensity till you find a sort of a comfort zone. Don't get too caught up in this fat burning, carb burning, because if your intensity is higher, there's also the evidence that for the next few hours, you will burn a few more calories. It's called EPOC, excess post exercise oxygen consumption. So if you are a little bit more intense in your workout, you'll burn a few more calories in the hours after exercise. So it's not as cut and dry as only zone 2 is good and not, but the bottom line is zone 2, zone 3 is a good zone to be in. The other practical aspect, Roshani, is in our weather conditions, okay, in India or in Mumbai. If you're exercising outdoors, it's hot and humid most of the year. So I've noticed that your heart rate for the same effort tends to be a little higher in these hot, humid conditions. Okay, so for example, the last few days we're enjoying good weather. So you'll see runners around you and yourself that you'll be doing the same speed, for example, at a lower heart rate. So because our heat and humidity is high, it tends to push up the heart rate. So sometimes people are a slave to their devices and they'll find that their heart rate may be going a little higher, but they are comfortable, they can carry on a conversation. So when that happens, I tell them, don't worry, don't
Keep
get
going.
yes, keep going, don't get too caught up. Exactly.
I need to
Zone
slow
1,
down, come
zone
back
2,
to
yeah,
zone 2.
you can have your conversation, you're good to go.
So the talk test is more important than just the number.
In a practical way, I say yes. If you're a numbers geek, it's nice, let's combine things, and you will find that over time you'll be able to do the same level of exercise with a lower heart rate as you get fitter.
Because you're getting fitter.
Absolutely.
Because your heart muscles are getting that workout.
Stronger, more efficient in a manner of speaking.
So one example I saw, or an analogy I understood, which helped me understand why I focus on zone 2, and I think you confirmed that, was the concept was of a pyramid where it's zone 1, zone 2, zone 3, zone 4, zone 5. And they said that if you spend more time in the zone 2, the base of your pyramid gets bigger.
Yes.
So the volume of exercise in that zone gets bigger.
Absolutely.
Your pyramid is more stable. It's a broad,
Absolutely.
strong structure.
Absolutely.
Versus if you try and do too much of high heart rate training when you're
Yes.
not trained for it.
Correct.
The analogy they give is the Leaning Tower of Pisa,
Yeah.
which is like tilting, because
Yeah.
instead of being strong on zone 1, zone 2,
Yeah.
you're getting top heavy, and zone 4, zone 5 heavy on the top, and you're
Yeah.
not stable. So is that a fair?
No, that's a great way of looking at it. And in a lighter vein, if you do a lot of work in zone 2, you won't look like a pyramid. So,
Well,
but-
yes, it's the fat
but
burn.
but that's a good way. So when the whole high intensity thing came into fashion, and people still do it, a lot of CrossFit, all of that, and I have nothing against it, but like you very correctly said, get your base right. Otherwise, it's a recipe for injury more than anything else.
And that's what we don't want. If you're talking preventive health, you're talking
Yeah.
longevity.
And you want long-term stuff, not flash in the pan kind of
No,
stuff.
we want something you can actually stick with and
Absolutely.
do it for the rest of your life.
Yes, yes.
So we need a cardiologist when this question comes up. Is you hear in the news, tragedy, a young person was running a marathon and collapsed and didn't make it, couldn't be saved, and they just died running. And suddenly just dropped. Nobody knew, nobody expected it. They'd been training for the marathon, and out of the blue, the person's no more. And it puts a lot of people off, and they say, yeah, that's why you shouldn't do extreme stuff, and marathons are too extreme. So I don't know. I mean, we just, talked about zone 2, but should nobody be marathoning? I know you run yourself and you are one of the doctors for the Mumbai Marathon. So I bet you're not going to say that marathons are for nobody, but should everybody be running marathons?
Okay, so there's a lot to package in that. And disclaimer: I ran 14K this morning, so for whatever that's worth. Um, this is a topic on which I've been speaking, writing, been asked about on podcasts, at cocktail parties, wherever I go, about this exercise, too much exercise. And the irony is, I have spouses coming to me where in the past they would say, my spouse is not exercise, talk to him, it's usually a him, and he's not doing. And then now it's the reverse, talk to him, he's exercising too much. So how do we unravel all of this? And let's take some time on this because it's a serious topic, and unfortunately in today's time everybody wants a headline, and this cannot be answered in a soundbite or a headline or even the newspapers. So firstly, anytime someone passes away and it's associated with exercise or during exercise, of course, it's going to create a far more impact. It's going to be sensational. So, person in gym dies is a headline, but person sitting at home watching TV is never a headline. Person sitting at work in the office and died is not a headline. And again, I don't mean to trivialize it in any way, but the point is that it's disproportionate coverage when a person's exercising versus the thing, right? So that's first thing to keep in mind. The second thing to keep in mind is whenever something happens, the press, the media will always label it as a heart attack. Now, earlier on, we spoke about the heart muscle and the blood supply is compromised and a part of the heart muscle dies. That's a heart attack. Now, when a heart attack happens, occurs, it could be, to put it in simple language, minor, in which a small part of the heart muscle dies, which is bad, of course, but the person lives. Or it's major when such a large part of the heart muscle dies that the heart then goes into what's called a cardiac arrest. In simple language, the heart stops working.
Stops beating.
Stops beating. So a heart attack is a leading cause for a cardiac arrest. But a heart attack and a cardiac arrest are not the same. Cardiac arrest means heart stops beating. So for example, if you get electrocuted, you'll have a cardiac arrest. Your heart will stop beating.
But it's not a heart
It's
attack.
not a heart attack. So research has shown that in the younger age group, and they've usually used younger as sort of 35 and below, a heart attack is rarely the cause of death. Not never, but rarely. They're different conditions. A common condition is a condition called cardiomyopathy, which in simple words is when the heart muscle sort of swells up or becomes bigger, but it's weak. It's not bigger and strong. It's flabby. Like sometimes you see, old people who may be overweight, they may have big arms, but they're not strong. They're flabby. So that flabby muscle is not a good thing. And those people, when they are in situations of sudden exertion, or sometimes not even sudden exertion, the heart goes into a bad rhythm, which leads to cardiac arrest. There's also an entity where they're talking about, which they call SUDS, sudden unexplained death syndrome. In simple words, after autopsies also, we don't know.
We don't know.
And that is the reality of it. So that's in the younger age group. Sometimes their heart arteries, the one I spoke about, their origin is from a different place from where it ought to be. So a lot of the young ones, you hear about young footballers on the field, 20, 21, 18, young basketball players. It's very common in African American basketball players. I mean, when I say very common, means relative to other sort of groups.
So it's a congenital defect almost.
In a way, yes.
But you wouldn't know because it's inside.
It's hard to know exactly unless you do a 2D echo, you do a ECG screening, and then they pick it up. But you just don't do it on everyone, right? So those are the commonest cause in the younger one, 30, 35 and below. Over 30, 35, the commonest cause is the blockage. And what happens is the blockage, think of the blockage like a volcano. So as we all know, a volcano can sit quietly or dormant for years to come and one fine day erupt. So that person had a volcano, had the blockage, and during that activity it erupted. So that exertion, when it happened, was a trigger for the volcano to erupt. So the heart wasn't completely healthy to start with. There was stuff going on, and that exertion was the final push over the cliff that caused it, right? So that is something that people need to keep in mind. It doesn't normally happen on a completely healthy heart. There are rare instances where it can, but that's very technical. We won't go into that. To answer your first question, should everybody run a marathon or should nobody run? And here is the advice I give to people. I tell people that for good health and to just be generally fit, it's a good idea to be running, or not running, to be exercising 4 5 days a week, 30 to 40 to 50 minutes, and that's great for good health. Anything you want to do more than that, let's say you want to run a 10K or 21K, that is not only good health, but it's also you want to achieve something. That's a goal you have. So if you want to do it and there is nothing medically preventing you from doing it, by all means do it
For fun.
for fun. But you don't have to do it. You don't have to run a marathon for good health. And just because you run a marathon, that's not bad. So both ways it works.
So the prescription of like the 30 to 45 minutes 4 or 5 times a week
Yes.
is probably the right dose
Yes.
of exercise for building a long, healthy life,
Absolutely.
healthy heart.
Absolutely.
Marathoning is not essential for a long
Not
life.
at all.
It's
Not
a
at all.
fun hobby. You like it. You're
Absolutely.
training. You do it.
Yeah, absolutely.
And
I want to
speaking,
add one
Yeah.
more point. Is that whenever someone who's healthy and fit, something bad happens, it creates a ripple in a community, and everybody says, "But he was so fit, but she was so fit." It's rarely she, because for different other reasons, women don't normally tend to have cardiac arrest during exercise. But they say, "Oh, but he was so fit." The point is, fitness gives you protection. It doesn't give you immunity.
not full immunity.
Remember, we spoke about all the risk factors. There's family history, there's smoking, there's cholesterol, there's blood pressure, there's diabetes, there's all of these things.
Stress.
And exactly, physical activity or inactivity is just one of them. So just because a person is fit doesn't mean they can't have a problem. To use my car analogy, it's like saying just because the car's brakes are working well doesn't mean it can't have an accident.
Right.
You need the brakes to working well to prevent an accident. But just because brakes are good doesn't mean you can't. So just because you're fit doesn't mean things can't go wrong.
Right.
So
You
that's
might
the
still
point.
have silent blockages.
Yes. Yes.
And we've seen this, right? I've had 2 friends and a colleague at work who are endurance athletes.
Yeah.
One was a cyclist, one was a runner, and one was like a sports person. And all 3 of these men ended up having blockages, which were caught in time where it was not a life-threatening event. It was more of a hassle. But let's talk about how would somebody know, what could they look for in there if they're regularly exercising? They didn't just get up and say, "Yay, I'm running the marathon."
Yeah.
But leading up to a big event or a big performance, how might they notice that I'm getting some signs that maybe there's a blockage that I need to think about?
Okay. So 2 points to that. The first is everyone must be aware of, like you said, signs and symptoms related to this. Okay. And I'll tell you the 2 cardinal ones. The first is what in medical terms we call angina, which most people have heard that term. And in the textbooks and when people talk to you, they typically say angina is pain in the left side of the chest going to the left arm. That's the definition. But in my experience, I would say 20 to 30% of people present in that way.
20 to 30 only.
Yes. The others are, it can be, and I hate using the word pain because many people say they felt a burning sensation. Acidity, discomfort, bhari laga. Okay, all of
Uneasy.
these. Uneasy, absolutely. And it's not just the left side of the chest, maybe the right side.
Maybe
It's
the
not
right
just the left arm, it may go to your right arm. It may radiate to your sort of neck and jaw. It may radiate to your back. So in my book, as you mentioned, I write that any discomfort from your navel to your nose, I use the phrase navel to nose, which is increased with exertion and comes down with rest, could be heart related unless proved otherwise. Get it checked out.
Get it
Now,
checked.
every time your shoulder hurts doesn't mean you're having a heart problem, right?
Sure.
But if you run and your shoulder hurts, you stop running, your shoulder doesn't hurt, then hey, let's get checked out. So the first thing is angina related symptoms. Second, which is even bigger, is what I call shortness of breath. To better define it, let's call it unusual shortness of breath with usual exertion.
Exactly.
What does that mean? Let's say you run 10 kilometers regularly at the speed of 9 kilometers per hour on a treadmill. And you suddenly find that now you get tired with 8.5, 9 kilometers instead of 10. Not just one day, but consistently. And you say, I'm just not feeling good. Acha nahi lagta hai. People use words like that. Maja nathi aati, they say in Gujarati. Right? These kind of things. And you find that it's happening routinely or more than once, twice. Or you find that you can do the 10 kilometers, but you need to slow down a lot. So that change is important. On the other hand, there may be someone who doesn't exercise and they'll be out of breath in 1 kilometer. So for that person being out of breath in 1 kilometer, I won't be worried.
Right.
But you who runs 10 regularly being out of breath in 8 worries me.
So it's a
So
drop.
a change matters. And ironically, a lot of these studies have shown a large amount of people who had a bad event happening in the week or two before that, they did get some warning signs, which they just took as part and parcel of training. Runners that are thoda out of breath, no big deal. And runners and endurance people do tend to be a little
Gritty.
gritty. Good word. Okay, so these signs and symptoms you really, really need to watch out for. If you're getting that, that's a warning sign. Please pay heed. At the same time, it is also true that there will be a segment of people who may not have signs and symptoms, whose tests were clear, and sometimes things happen. Okay, now that's a hard one, which brings us again to the topic of CT angio. I'm sure in your practice you have people asking you to do a CT
Yes.
angio. Should I not? And I get that question asked.
The premium body checkup.
Exactly,
Yeah.
very frequently. So what's a CT angio? Basically, it's a CT scan looking at the heart arteries. It's kind of like an angiography, which we do it, but it's in a CT scan. So it's
So
an easy
photograph.
it's a
Photograph of the heart circulation.
arteries.
Yeah.
Now again, if you go by guidelines of any worldwide heart society, no one tells you to do a CT angio routinely. And this is a tough one to answer. The way I view it, and this is just my personal way of viewing it, if someone comes to me and they have a high risk history, right? High cholesterol, family history, etc., etc., etc.
So somebody
Then-
died in their family young.
Exactly, especially if someone has died young. That's big alarm bells. Below 60, if somebody's had a sudden cardiac death, then I would be inclined to test it, especially if they are doing endurance events.
You would like to test CT angio for some.
I would, and I explain to them the pros and cons of the testing. There's also some radiation and things like that. If somebody has got zero symptoms, very low risk profile, I would never proactively recommend it. If they ask me, I want to do it, I don't stop them because again, in our country, it's accessible, it's not very expensive. But I do tell them that in a CT angio, sometimes you'll get a completely clear result, which is great news. Sometimes you'll get a horrible result on the other end. But oftentimes you get a little bit here and a little bit there. Now, how do you handle that news, right? Now, that plays with your mind. So that's again a different topic altogether. But
Okay.
that's the whole do you test or not bit.
And then there's like this in-between test, which I got, my husband and I got, is the coronary calcium score.
Yes.
What is that and is it good?
Good point. Yeah. So a coronary calcium score is done in the same way that you do a CT angio, but all you're looking at is calcification in the arteries. Now, let me first say that calcium in your coronary arteries is not the same thing as your blood calcium levels, or it's not if you're eating food and calcium, so don't confuse the two. What they found is that when blockages happen, some of the blockages get calcified.
They get hard.
They get hard, they get calcified. So that calcification is what's called a surrogate marker for potential blockages.
Because you shouldn't have calcium in your
Coronary
arteries of
arteries.
the heart.
But let me tell you two things which also confound the issue. One is you can have zero calcium, but you could have what is called soft blockage, a soft plaque, which ironically is more likely to rupture.
It's like the top of the volcano is like rumbling
Yes.
and crumbling,
Yes.
and it's not sealed off completely.
Exactly. So that is something which is dangerous. Like a zero calcium score, the person says, I'm home free, I don't need to worry about anything. So that can happen. Secondly, on the flip side, you may have a slightly high calcium score, but ironically, that calcium has hardened the plaque, and you may have a non risky plaque, a plaque which won't rupture.
It's like a very dormant volcano. It's not erupting.
It's not erupting. But of course, if your calcium score is very high, then we need to. So again, these are, my point is it's nuanced. These are not cut and dry. One needs to understand all of this before doing the test, talk to a doctor who understands the pros and cons, and then discuss the report with someone who understands the pros and cons. Like what happens if you get an intermediate calcium score? How do you handle it?
Right. You need to have someone you can talk to who can
Yes.
simplify it and explain
And break
what it
it down
means.
for you in your context.
Yes, and then you know your options and how to
Yeah.
go forward.
Yeah.
So we've talked so much about exercise and preventing bad things from happening. But the reality is you're in practice, I'm in practice. We see patients who have come with illnesses, and diabetes and cardiac disease almost go hand in hand. Where, like you said, having diabetes is almost like we consider it as good as having heart disease.
Absolutely.
Already. And we know that it's been for at least, if you've had type 2 diabetes, that there's been at least 10 years of things happening in the circulation, inside the blood vessels. We don't want anything going on in the blood vessels around the heart, and that's where the problem is. And that can lead to the heart attacks. So, and I know you spend a lot of your time doing rehab with such patients. So, what happens to a patient who's had a heart attack? Or maybe I have two questions. Have you noticed any patterns in terms of the amount of diabetes that you see in patients with heart attacks? And something that may have happened to them maybe in the prior week? Was there more stress? Were they not sleeping? Did they travel? So, what happened to them before the heart attack? Do you see patterns?
Okay, so I'll answer that question first. Um, you know, after COVID, I find a lot of the patients blaming their heart attacks on COVID, or some even blame it on the vaccine. Now, honestly, the research on this subject is literally just coming out because you got to go back all these years and look. And there is some evidence that, some little funny stuff may be going on related to COVID, more related to clotting of inside the heart arteries, where, relatively healthy people may be getting issues because of those blood clots forming. I don't have a strong view on that yet, but it's certainly a possibility.
We'll never really know, right? Because there's no other Earth, planet Earth, where this vaccine was not administered to almost the
Yeah.
entire population.
Yeah. So that's one that I've seen people. A lot of people attribute their own sort of events to stress, or in relation with some stressful event, but the vast majority, there really isn't a specific point that really stands out. In terms of diabetes, ironically, I think I would like to say about half the patients have diabetes. So, when sometimes they come to us and say, doctor, diabetes chair, I said, yeah, so join the club almost. It's like everybody. So today, cardio diabetes is like one. And a lot of the guidelines on cholesterol lowering, all of them are same, whether you have diabetes or you have heart disease. And as you know very well, insulin resistance is your pet subject, and that tends to be a cause of a lot of it. So I think that this whole insulin resistance syndrome, metabolic syndrome, earlier they call it syndrome X, is probably present in 30 to 40% of our adult population. Have you seen that? What is your experience in that?
Yes, it's probably, like you're saying, it's actually even coming to 1 in 3 kids now, metabolic syndrome. So obviously they're too young to develop cardiac disease,
Correct.
but they're getting a head start compared to their parents.
Yes.
Where the parents, we just bucketed them like 35 plus is when we would
Correct.
think. These children, if they're having these lifestyles, and you and I care about that, is what are we putting into our bodies? How are we resting? How are we exercising? These kids are not getting what their parents maybe have gotten. And this is now the first generation where these kids may have less longevity projected for them, less lifespans because of all this insulin resistance from childhood.
How do they present to you?
Gaining weight,
Okay.
growing paunch. So I'm an adult endocrinologist, so people would come to me once they're 18, but you see the story or the journey with the pediatric endocrinologist that the child is gaining weight. A young girl might come with irregular periods, PCOS. We know that PCOS and heart disease goes together. That the young lady who has PCOS now, she's going to have higher risk for cardiac disease in her 30s and 40s. So we do see this increasing trend, darkening of the skin on the back of the neck, acanthosis. So the dermatologists will, pick it up sometimes, and because people don't come to an endocrinologist,
Correct.
we are like way hidden away. Nobody really knows that they should go see a hormone doctor for darkening of the skin or for irregular periods. But these are hormone imbalances.
Correct.
And insulin resistance is the hormone imbalance that drives diabetes and cardiac disease, if I may say so. Insulin resistance plays a big role in the inflammation of the circulation, and the blood vessel lining is not healthy. And maybe that's what causes the volcano. So we won't know what's the chicken and the egg.
Yeah. They say that ultimately heart disease is an inflammatory disease, and that applies to several other parts of the body. And if you can get the whole inflammation down, that's the theory behind it. And as you said, younger people are getting it. But in terms of diabetes and heart disease, and exercise, one very interesting thing that I found. So we do sugars before and after exercise for our diabetics, especially the first few times to get a sense of where they're going. And you'll be amazed as to the drops that you get with just simple exercise. I'm talking about 10-15 minutes of a walk, 10-15 minutes of a easy cycling, and their sugars will be 200 to start with and end up at 130, 140. So I think exercise has this fabulous way of, if I may use the phrase, normalizing blood sugar.
Yes.
And I think especially the ones who are on insulin, their insulin requirement drops. Do you find that?
100%, Ashish, and I'm really glad you brought that up. So, in my book, as you know, I talk about muscle, and there's this three musketeers concept, which is the liver, the muscle, and the pancreas cooperate and coordinate glucose levels. And the muscle's job is to be the glucose taker. So, like you said, 10-15 minutes of activating muscles. And you also mentioned how you're using carbohydrates or you're using sugars to fuel your movement, fuel your exercise. That's that glucose, the instant glucose that you can get someone from uncontrolled diabetes into normal range. So it's so powerful. Do your patients love to see the drop, and are they
They
like,
do. They get excited. So I tell them exercise has an insulin-like effect.
yes,
So and the strange thing that I found is that the same patient today may come in with 200, and after exercise the sugar will become say 120. So they say 80-point drop. But tomorrow if he or she comes in at say 150, it won't become 70. 150 will again become 120, 130. That's why I keep seeing the body has a way of normalizing it, and it's just marvelous to see.
yeah, it's always looking for that balance. And one thing that I make it a point to do is I get on the phone with the personal trainer or the physical therapist of my patient with diabetes, so that when they go do this good stuff, all this exercise, and the glucose tends to come down, I can be part of that to cut the insulin doses, to reduce the medication that's causing the risk of the glucose going into hypoglycemia or a low glucose. Because naturally you can get it down by using the body, using the muscles. So we need to reduce the diabetes
No,
medication.
I wish all endocrinologists across the world were so hands-on.
100%, because otherwise, see, now this is where it gets troublesome, is if we don't participate together and coordinate, what will happen is you may reassure the patient in your clinic, but someone at home or the patient themselves will be scared.
Correct.
It'll go low, and they'll say, I better eat something before,
Correct.
or I better eat as soon as I get out. What if it falls lower? And now you've taken someone who came with insulin resistance, metabolic syndrome, increasing waistline, and they're now having to eat to protect themselves from exercise.
Correct.
So it's backwards.
So it becomes a vicious cycle almost.
It's the vicious cycle. So unless and until we take out the prescriptions that are pushing the glucose too low, they won't break free. And they're putting in all the efforts. So the least we can do is reduce the unnecessary medication.
I agree.
Okay, so we were talking about how do you increase your lifespan. We talked about the zone 2. But there's this other term, and I actually showed up in your lab because I just read Peter's book and we wanted to just geek out and showed up, and you had us run on the treadmill with this like mask, like a astronaut mask, and you tested us for the VO2 max. And I personally kind of understand it, but what exactly is the VO2 max
Okay,
test?
so firstly, I think your viewers must know that you're very fit and you're one of the doctors who is walking the talk, or should I say running the talk. So that's great. VO2 stands for volume of oxygen and max. So we need oxygen to survive. Everybody knows that. At rest, all of us are roughly consuming 3.5 ml of oxygen per kilogram of our body weight per minute. So you and I both consuming 3.5 ml per kilogram, but of course your kilogram and mine are different. So in absolute terms, it's different. And that is considered to be, the technical term is called 1 MET, MET. 1 MET is our resting.
Rest.
As we start doing activity, any activity, like right now, so complete rest is lying down. Did you do a resting metabolic rate? Because we test that as well.
I don't think
So maybe
so.
next time we do that.
Yeah.
That's when you're completely lying down and we get, how much fat you're burning, carbohydrate. You'll be
Oh
interested
yeah,
in that.
yeah, I would love
It's
to
called
see
an
that.
RMR, resting metabolic rate. So sorry, I'm digressing. But if we do, when you're resting, that's like the minimum oxygen you're consuming. As we get up, we sit, we talk, we're walking up steps, we're walking a little bit quicker, you're playing a sport, you keep increasing your VO2. The maximum oxygen that you're able to consume at your maximum exercise is known as your VO2 max. Okay, so for example, we put you on a treadmill and we put that same Bruce protocol, the protocol we use in the stress test I spoke to you about, and the push you to max, and we did it without you holding on, and you actually went till you could go no further. And we're measuring the oxygen that you're breathing in and your body is consuming. So that's called your VO2 max. A good value, depending on age and sex, is anywhere upwards of 35 to 40 ml per kg per minute. World class values are 60, 70, 80 in that zone. So, what studies have found, and Peter Thiel writes that in his book, and a lot of patients are asking about it, is that those who have the highest VO2 max, rather, is a very good correlate of longevity. But the truth is, it's not VO2 max per se, it's a simpler word, it's fitness.
Cardiac health.
Fitness is a correlate of longevity. And of late, there were two studies that came out in 2018 and 22. One looked at the veterans in the American setting, and one looked at, it was a Cleveland Clinic study. One was, I think, 750,000 people, and one was 150. And essentially, what they do is they test them, and then they divide them into categories of fitness. Let's say if they tested 100 people, they'll just say the top 20 scores, the next 20, next 20, next 20. And they found that the ones in the lowest category had a several times higher risk of dying than the ones in the highest category. And that's how they know that VO2 max is a great surrogate marker of your cardiovascular fitness, etc. And they found that those who have the highest fitness levels tend to live longer. And the irony is that this has been around for a long time. So I don't know if you're familiar with the Cooper Clinic. The Cooper Clinic, Dr. Kenneth Cooper is the first doctor in the late 50s, early 60s who coined the word aerobic. We didn't know aerobics, the phrase was coined by him. I think he's still alive. He's probably in his mid or late 90s in Dallas, Texas.
So he's cracked longevity.
And it's called the Cooper Clinic, and a lot of the American presidents go there for their annual fitness tests and all of those. And they've been measuring people's VO2 and their fitness on treadmill tests for years and years. And they found that, again, the same thing, that those who had the highest fitness had the lowest risk of what they call all-cause mortality, which
Dying
means
from
death
anything.
from any cause. Then they subdivided it into heart disease, cancer, everything. So fitness tended to provide you protection against all these bad things, including cancer, heart disease, and all of it. But the good news, and all of these studies found a graded association. What does that mean? The fittest people had the best results, then the next, then the next, and then the next. But the good news was, and that's a great public health message, that the biggest, if I use the phrase bang for your buck, you get is not by becoming the fittest person, is just from moving from the least fit to the next level. So moving from the lowest 20% to the next 20 gives you the greatest jump. Then moving from there upwards, 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 you get benefit, but then not that much. So the best benefit you want is just get off the chair, walk 20, 30 minutes a day, and you almost getting similar benefits to people doing a lot more. So that's the whole VO2 max piece.
Got it. So you don't need to get a complex like I'm not an elite athlete level
Not at
VO2
all.
max,
Not
but
at all.
can I train to improve my own VO2 max?
Absolutely. And that's the whole thing. Getting better is the game, right? So it's a nice, by doing it, it's a very objective number which you can get, and then you can work to improve it.
So would you say that that's like almost like an anti-aging thing to do?
I think it is one aspect of better health. And as you start moving towards the journey of better health, it's going to help. And better health, there are three big, or let's say, yeah, three big pillars. One's exercise, one's diet, and the third is what we call the whole mental health, in which things like even sleep and all come in. But that's 90% of the game. The other nuances are 10%. If you get these three things right, that's most of the work. But that's hard work. It's simple, but it's hard to execute day after day, year after year.
Most of the truths in life are simple, but they're the hardest to do.
Ain't that the truth?